I see Lane and Jansen are on here. Do either of you guys want to start sharing your screen so that the cover thing is on?
Yeah, I'll share my screen.
Right.
In 1 second. Oh, you disabled the screen
I
sharing.
was turning it on. Go ahead.
Let's see. Here we go. Share this. View. Present.
Beautiful.
Oops.
No, he's coming back. the work.
Hi, everybody. Thank you so much for being on time at 6:30 right now. We'll just go ahead and give everybody others a few more moments to join in and get settled. Oh, and if you could put your name in the chat for attendance, please do. All right, folks, this is Robin. I'm going to start my video. This is Robin, and I am so pleased today to introduce you to one of, I think, crowd favorite session for AHEC scholars. It's called Peer-to-Peer IPE. And the idea is that you're going to learn from your peers about how they feel about their profession, what are the top reasons that someone might refer, those kinds of things. And so today we are lucky enough to hear from Audiology. And so we have Lane Hammonds, Masa Abidi, Val Rabin, and Jansen Viator. Did I miss anybody?
Nope.
Awesome. Okay, so I'll go ahead and turn it over to you guys. And I hope everybody really enjoys this.
All right. Hey, guys. All right. It was a very bad camera angle, but anyway. All right. So me, Masa, Valentina, and Lane, we are going to be presenting on audiology. So my name is Jansen, and I am a fourth-year resident, and I'll let the rest of the group introduce themselves. So if y'all want to just go in order of the slide.
I'm Valentina. I'm a third year.
My name is Masa, and I'm a second-year student.
Hey, my name is Lane. I'm a second-year student.
All right. So, why is it not? Okay, there we go. Got to click. So your learning objectives today are to be able to identify the field of audiology, just kind of become familiar with things that we do and as professionals, become familiar with common hearing and balance related pathologies, and also be able to identify when to refer to an audiologist. Okay, so about the audiology program. So the audiology program is actually 4 years long. 3 of those years are coursework. So we're doing classes as well as clinicals. Um, Clinical sites can vary depending on where you're put. Some of them are private practice, some are ENT, some are pediatric. Most of them are, I would say, ENT and private practice. Sorry, my cat doesn't like it when I talk to other people. There is a built-in residency. So after you finish your 3rd year, you begin your residency. You do have to find this on your own. It's kind of like finding a job. And then for the 4 years that you are in the school, you have to get 1,820 hours of clinical work to get your degree. And then upon graduation, you are rewarded with a doctorate in audiology. So every AUD or audiologist has a license has to have a license in the state that they work in. Some additional certifications may be earned. Some of the most common ones are through ASHA, the American Speech Language Pathology and Hearing Associate and Audiology. Sorry, forgot to put Audiology Association for clinical competence, and then also through the American Board of Audiology. There are other ones that you can get, but these are the 2 that you'll see most often. And I do want to mention that there is a difference between an audiologist and a hearing instrument specialist. A hearing instrument specialist only goes through nine months of training before they get their license and they dispense hearing aids. Audiologists obviously have gone through 4 years of training, and they can also do some more medical stuff as well. So just be wary of that if you are gonna, if you see an audiogram done by a hearing instrumentation specialist, they're kind of, don't have as in-depth of an education as an audiologist would. Oops, wrong thing. So primary roles of an audiologist, some of the topics that we deal with are tinnitus or tinnitus, cochlear implants, BAHAs, which are bone anchored hearing aids. We do pediatrics, geriatrics. We do interoperative monitoring. The most common thing that we are known for is hearing aids. We also do vestibular work as well as hearing conservation and ototoxic monitoring. Where would you find an audiologist? So we're kind of all over the place, mostly in ENT and hospitals. There are some of us in school systems. Most of us will be a private practice, so we'll probably run our own place. Industrial for hearing conservation. We also work at the hearing aid manufacturing businesses. We have those in higher level academia, so our professors, our PhDs, our researchers. We can be in the operating rooms for some surgeries and also in nursing homes. So some risk factors for hearing loss, these are big red flags for us. If the patient has diabetes, heart disease, if they've had chemo or radiation, if they've taken ototoxic medications, if they've had a trauma to their head, if they have autoimmune diseases, noise exposure is number 1, of course. If they have a family history, that's another very big red flag because hearing loss can be genetic. Just like genetic disorders, there are over 400 different genes that code for hearing. So there are quite a few genetic disorders associated with it. Viral infections can cause this, and also kidney disease is also a factor. On this other side, hyperbilirubinemia, NICU stays, gestational diabetes of the mother, TORCH, which is toxoplasmosis, other things, other diseases, rubella, cytomegalovirus and herpes simplex viruses, anoxia, and craniofacial anomalies. These are more pediatric. Of course, there will be a record of this as they grow older, but usually if you're seeing a pediatric patient, you would look for these big red flags. Okay. So this is an audiogram. This is how we evaluate your hearing. So on the x-axis is your loudness. This is how loud we have to turn it up for someone to be able to hear it. So up here is about a whisper. Down here is obviously like a jet engine. Okay. Here are your pitches that are important for speech reception and understanding speech. So these lower pitches, about 250 to 1000-ish. These give you your loudness, your volume. These are your vowel sounds, your A, E, A, O, U. Those give you your volume. From about 1.5 to about 4,000, these are your clarity pitches. So those consonant sounds, those very fine, like t, sh sounds, the difference between fin, thin, and sin, how we are able to distinguish our words. This is where all of those sounds fall. And most people will have a higher frequency loss. They'll typically have good in the lower pitch, not as well in the higher pitches, and they'll complain that they have clarity issues, or I can hear you but I can't understand you. If you ever get that somewhere in your practice, they most likely have a sensory high frequency loss, and this is most of the time this is aidable. Anything that falls below 25, so from 25 down, is considered hearing loss. One thing we do want you to keep in mind is that hearing loss is perceptual. So I'm in the clinic and I do every day, and I do see some people who are right here, just right out of normal range, and they're like, I can't understand, I can't hear, and even if they're complaining of that, we still want to look into it. And sometimes hearing aids actually do help these people. So even if you always refer to an audiologist, even if they're saying, hey, I'm having trouble, with this, especially when speaking and understanding, I would refer to an audiologist for a hearing test, because it's always good to have a baseline test. Okay. There are actually 3 different types of hearing losses. The types most common is sensory neural. It refers to the damage that is either in the inner ear, which is your cochlea, that is your hearing organ, or the hearing nerve, which is your 8th cranial nerve. It's irreversible and tends to be progressive in nature. Wear and tear, noise exposure tend to exacerbate this. A conductive hearing loss is a little bit different. It refers to a problem with the sound mechanism. So it involves issues with your pinna, your ear canal, your eardrum, and your middle ear bones. The cochlea and the nerve are usually intact for this type of loss. A lot of people have had trauma, perforations in their eardrums. Otosclerosis can cause this type of hearing loss, but this is a very easy fix because all we have to do is just raise the volume louder in order to get it to your brain. And then there's a third type, which is a mixed hearing loss, and as you could guess, it's a mix of sensory and conductive. So many people who have these problems have had traumatic or chronic problems throughout their lifetime. So multiple infections, some of them, have had car accidents, and it can cause both, problems with the conductive mechanism and the sensory mechanism.
Okay, I'm going to talk about hearing screening programs. Hearing screening is a quick test to see how well an individual can hear different sounds. The result of this test is pass or fail. The purpose of the screening is to determine if the person has normal hearing or not. It's important to keep in mind that if someone passed the hearing screening, they most likely have normal hearing, but if they fail the screening, it's not necessarily showing that they have hearing loss, because there might be something else like background noise or earwax that can result in failing the screening. Screening can be done at any age and in a variety of settings, including hospitals, schools, doctor offices, health fairs, or workplaces. And regular hearing screenings will help individuals to keep track of their hearing and get help when needed. Next, please. So newborn hearing screening is the most important screening program and is the standard of care in hospitals nationwide. Newborn screening is done to identify newborns who are likely to have hearing loss and identify newborns who with medical conditions that can cause late onset hearing loss. Early hearing detection and intervention, or EDI, is a protocol refers to the practice of screening every newborn for hearing loss prior to hospital discharge. So basically, the purpose of this program is to identify newborns who fail the screening and make sure that they receive diagnostic evaluations before 3 months of age, and make sure that if the hearing loss is confirmed, they're getting the help that they need, and early intervention is started by 6 months of age. Next, please. So now I'm going to talk about 3 important ear-related problems that it's good to know about and are very common. One of them is noise-induced hearing loss. This can result from damage to structures and or nerve fibers in the inner ear in response to loud sounds. Noise-induced hearing loss can be temporary or it can be permanent, which means that it cannot be medically or surgically corrected. Noise-induced hearing loss can result from a one-time exposure to a very loud sound, blast, or impulse, or sometimes it can occur due to listening to loud sounds over an extended period. To prevent noise-induced hearing loss, we need to avoid or limit exposure to excessively loud sounds, turn down the volume of music systems, move away from the source of loud sounds when possible, and use hearing protection if moving away from the sound source is not possible. I also wanted to mention that based on CDC report, there are over 22 million US workers that are exposed to loud sounds that can result in noise-induced hearing loss. And there are different organizations that are working to improve safety of the workplace and minimize noise-induced hearing loss in the workers. One of them is called OSHA, or Occupational Safety and Health Administration, and they are basically measuring the sound level in different work environments. And if the sound level is higher than their limit, they're gonna basically recommend hearing conservation program, and that is going to be mandatory if the worker is exposing to loud sound. So they have to use hearing protection, and they also make sure that these workers are getting tested annually. Next, please. Another type of hearing loss is sudden sensory neural hearing loss. It's also known as sudden deafness. It's an unexplained rapid loss of hearing, either all at once or over a few days. This is a damage in the sensory organ of the inner ear. It's usually in one ear, and the person notices that when they wake up in the morning, or sometimes when they're trying to talk over the phone or like using headphone, and they realize that they're not hearing out of one ear. They may also experience ear fullness, dizziness, or ringing in the inner ear, which we call it tinnitus. Most of the time, it's hard to identify the cause of this kind of hearing loss, but there are a variety of disorders affecting the ear and can cause sudden deafness. Some of them are like infections, head trauma, autoimmune diseases, exposure to some type of drugs that are used in cancer treatment, or blood circulation problems, neurologic disorders, or other diseases such as MS, or inner ear problems such as Meniere's disease. Next, please. So if sudden hearing loss occurs, there is a short window of time, maybe 2 weeks, when patient can be treated. And this is very important because with every day that passes, the chance of hearing recovery goes down. Although sudden sensorineural hearing loss in some cases is treatable because the symptoms are not very scary, many patients just ignore them until it's too late. So it's important to know that if you see anyone experiences sudden deafness or sudden sensorineural hearing loss, they need to visit an ENT immediately. So when they visit their physician, they usually refer them to audiologists for audiologic evaluation, and there is a criterion for diagnosis of sudden hearing loss, which is at least 30 dB loss in pre-connected frequencies within 72 hours. They also recommend blood tests, imaging, and balance tests to help with their differential diagnosis. For the treatment, the most common treatment of sudden hearing loss is corticosteroid to reduce the possible inflammation and decrease the swelling and help the body fight the possible illness that is going on. There are 2 types of implementing this treatment. One of them is oral steroid, and the other one is intratympanic injection, which is what you see in the picture. The physician might also recommend other types of treatments based on the patient's history and underlying diseases that they might have. Next, please. So another type of hearing loss is due to basically called ototoxicity. In some literature, they call it ear poisoning. It results from exposure to drugs or chemicals that damage the inner ear or the vestibulocochlear nerve. It can result in a hearing or balance problem, and the effects of ototoxicity can be reversible and temporary, but sometimes it's permanent and is not reversible. Usually, the first sign of ototoxicity is ringing in the ears. Next. There are more than 200 medications and chemicals that are known to cause hearing and balance problems. And there are more than 450 prescriptions and over-the-counter drugs that can trigger tinnitus, making the existing tinnitus worse or causing new tinnitus to appear. As you see in the picture, there are different ototoxic medications, and some of them are medications that a lot of people might use during their lifetime, but some of them, like cisplatin, which is a chemotherapy medication, which is used to treat a number of cancer, is very ototoxic. It's basically the most common ototoxic compound in clinical use. There are still a lot of research going on ototoxic medications. For example, recently, some literature showed that if a patient has liver problem, and they get profound hearing loss overnight if, in case of oxycodone acetaminophen overuse. So it's very important to make sure that if there is a sign of hearing loss or tinnitus or balance problem, when treated with a new medicine, we need to refer to audiologist or consult with the physician. Next, please. So unfortunately, the damage from ototoxicity may go unnoticed by patient until it has advanced enough to cause obvious hearing and communication problems. that's why early identification of hearing loss and balance problem is very important. And if it's identified early enough, they might be able to prevent the impairment. The most effective barrier against ototoxic hearing loss would be routine hearing tests and retain the records so that they have that baseline measurements. And if a change occurs, the physician might be able to adjust the dosage or switch to another medication for that type of treatment that they are getting. That was it for me.
Okay, so there's a lot of different things that can cause hearing loss that we talked about, and audiologists are just very important as like an important puzzle piece, working with otolaryngologists and other physicians to figure out everything. But once you receive approval for amplification, that means that we have ruled out any pathology such as acoustic or vestibular schwannoma and things like that. We can move into the amplification side of everything. So I wanted to talk about the three main types of amplification. The first being hearing aids, and I kind of wanted to show people a picture because you can see how small they have become and how we have some. This is one of our examples that we have some that fit completely in the canal that are completely invisible. This is called a RIC, a receiver in the canal. And then we have some that are behind the ear as well, just a little bit. They have more of a plastic tubing, and those are for our individuals that need a lot of amplification. But we've really scaled around helping people with cosmetic issues, because you wouldn't imagine the amount of people who won't wear them just because of cosmetics. And for that to be a determinant to your health or detriment to your health is a big deal. So hearing aids are small devices that fit in or on the ear, worn by an individual with hearing loss in order to amplify sound. But they work way better than just amplifying sound. The technological advancements have allowed for programs to aid with tinnitus, to aid in sound quality, to aid in directionality. For example, if someone's behind you, the hearing aids are able to automatically go into a program that picks up sound more from behind you and makes it seem like it's coming from in front of you auditorily, and just allows you to really encompass the entire environment. And then also uses filters to cut out very loud noises that might be painful, or even like the noise like the refrigerator running right now, or if it's too loud, it wouldn't be amplified, it would just be cut out. And so that's something really important. And then I put in something about rising of the over-the-counter hearing aids. Over the next couple of years, the FDA has just recently approved over-the-counter hearing aids, and that's a whole story in itself. And kind of how we stand is we're kind of against over-the-counter hearing aids, because you're not going to be able to educate individuals on how they work, or you're not going to get the prescription to fix your hearing loss. That's kind of how we describe it to people. And that those are just going to amplify all sounds, and it's going to end up losing money in the end because it's not going to be beneficial to patients. So I kind of look at it as like educating patients, because these are already expensive devices, and insurance is getting better at providing them, but right now insurance is not meeting the mark for a lot of people. So just remember that as you might have people asking you questions about over-the-counter hearing aids. We'll learn more about that as they begin to come out. And then a bone-anchored hearing device, or BAHA, as some call it, is surgically implanted hearing device into the bone, and it aids through direct bone conduction and is less invasive than a CI. And so a lot of people who have functioning hair cells and their cochlea are functioning very well have really benefited from BAHAs. And then cochlear implantation are electronic devices implanted into the temporal bone through the round window of the cochlea. And these are for individuals who do not obtain any benefit from hearing aids. So you must go through like a hearing aid trial, and you have to meet certain criteria to even be eligible for CI. And then audiologists work with the surgeon to help with the surgery to ensure everything is going smoothly. So some common questions regarding tinnitus, which is a ringing in your ears without external sound source. There is never, as so far has been a cure. There are treatment methods, and we try to educate people on different treatment methods, which is kind of like a step. You start somewhere and you have to go. But tinnitus can be very, very exacerbating for some people. I don't know if anyone saw, but it happened last week. The owner or the CEO of Texas Roadhouse had acquired tinnitus after having COVID, and he committed suicide. And so this is one of our big things that we kind of watch out for, because it can really affect people psychologically. And so some treatments have been high salt diet, caffeine, medications like a lipoflavonoid over the counter has really helped some people. Reducing stress, and then noise exposure is the main cause. And people believe that the etiology of it is damage to those hair cells. I know there's been theories put out there that we all have the ringing, but our brains are just able to kick it out. As I was saying, the fridge is running right now. I'm not listening to the fridge because my brain is able to cut out the noises that aren't important to the environment. And people who lose their hearing aren't able to do that as well, if that kind of gives you a little understanding. Cerumen impaction with earwax causes a lot of conductive issues, especially in pediatrics and our special needs patients. And so this is something we check for, and there's ways to remove it. And I don't know if y'all have heard, but we, in our scope of practice, and it's kind of like a weird line. We're allowed to remove earwax, but it's up to the decision of the audiologist if they want to move forward with that. Some people, if it's too deep, they might not feel comfortable. They're not like right with the ENT because damage can be caused if it is done incorrectly or if an accidental mistake is made. And this can cause that conductive hearing loss. Yeah, so I said that. And routine care can be over-the-counter products like Debrox or Audiologist Choice, which is just a few drops. All right, so now we're going to go into another side of audiology that a lot of people don't know. You hear audiology, you think of hearing loss. Well, we do a lot with balance. And so just to go over the balance portion, you have your sensory input, which is vestibular, visual, and proprioceptive. And those all work together through integration through portions of the brain and the brain stem. And then you have your motor input, which is like your vestibular ocular reflex, motor impulses to control eye movements, and then the motor impulses to make postural adjustments. And so that is our balance. So looking at the vestibular organs, you can see the cochlea right there with the basilar membrane, the hair cells. That's what we had been talking about for hearing loss. Well, connected to them are three large semicircular canals, posterior, superior, and horizontal, and these all detect angular motion. They are each filled with endolymph, which is also in your cochlea, in the scala media. And when the head rotates, the fluid within it lags due to inertia and exerts pressure against the canal sensory receptor. And so it's that inertia which is telling your head what the movements are. And so something interesting is our ears work together. So me moving my head does not cause dizziness because both ears are detecting the same linear movement kind of in opposite directions, and we call that common mode rejection. And whenever one ear is not working correctly, that's kind of when you see a lot of issues as well. And then you have your utricle and saccule, which are detect vertical and horizontal movements. And so embedded in the utricle and saccule are small calcium carbonate crystals known as otoconia. A lot of times people come to the clinic, if they've had dizziness before, they'll be like, oh, my crystals are unaligned, and they'll just be talking about the crystals, and that's what they're talking about if you ever hear that. And they provide weight to that sensory organ. They're like literally just like hanging on. And so that weight changes in the weight by moving your head in different angles is what sends that sensory receptors. And when those crystals become dislodged, they can enter other portions, including the canals, and cause dizziness known as BPPV, which we're going to talk about in a little bit. But that's one of the number one causes of dizziness. So assessments and testing for BPPV, we work really closely with PT, but we do a lot. I feel like we do more of the testing and they do a lot more of the therapy if needed. But it's a very close relationship that you have to have with them. And so a lot of audiology is working with other professionals. And I think that's why it's important that we all understand each other's role. And so the new gold standard for testing the inner ear and the central motor functions is video nystagmography testing, which is called VNG. This is an advancement from ENG due to the ability to measure the movement of the eyes with the infrared cameras. The ENG, you weren't able to measure the exact minute movement of the eyes. And by measuring all this, we get to tell if it's peripheral in nature, like in the vestibular organ, or if it's central in nature, which is like more in the brain. And there's four main parts: is ocular mobility, being able to use your oculomotor muscles correctly and they move in the correct patterns, the correct speed. We have optokinetic nystagmus, we call it OPK. Positional nystagmus, which is where we put you in different positions, your body at different angles, and that might elicit some movement of the eyes. And then caloric testing, which is where some older practices might put some like temperatured water in your ear, and that we look at the movement of the eyes. And then a lot of times now we use air calorics, which helps in a lot of different areas. There's posturography, which is PTs do a lot of posturography for like therapy. The testing procedures for upright posture, balance, sense of equilibrium, done with the patient standing on a platform that moves, and that platform can measure like the smallest movements of your body. And we have rotary chair, which is used to determine if the vestibular inner ear or the neurological system is the cause of a balance disorder. Also measures our eye movements. And this is especially useful whenever you can't get good VNG results and for the assessment of bilateral vestibular loss. A lot of times VNG testing is very difficult. A lot of times people can't do it either due to, because it's a lot of moving around. It's very hard to do on children. I don't know if I've ever seen one done on a child. And then there's bedside assessments like the head impulse test, known as VHIT. You'll see they'll kind of put the goggles on, or they'll watch really close and they'll just move the head real quick, like this. And they're able to get some findings from that without having to go, if they might warrant the VNG following that.
Okay, so like Lane said, the most common cause of dizziness is benign paroxysmal positional vertigo, which is also known as BPPV. It occurs in over 40% of patients with dizziness problems, so it's super common. It can affect any age, but we particularly see BPPV in the older population. And we start seeing that, and the incidence increase in individuals about 50 years old and up. So characteristics of BPPV include brief but very intense episodes of vertigo lasting several seconds when the head moves in certain positions, and it's often accompanied by a general sense of imbalance without head movements as well. So what happens in the inner ear? What happens is that in the inner ear, the crystals, which are called otoconia, for whatever reason, they get displaced in the semicircular canals. About over 90% of these cases are caused by free-floating crystals, and this is called canalithiasis because it gets stuck in the canal. And less than 10% of cases are caused by the crystals getting lodged in part of the vestibular organ that senses spatial orientation. So the sensory organ is called the cupula, hence this form of BPV is called cupulolithiasis. So what happens when a patient comes in with BPPV? Well, we take a thorough case history, we do some maneuvers to determine if it is in fact BPPV and what type. Most of the time, patients have posterior canal BPPV, and our most common maneuver is one called the Dix-Hall Pike. So we do this maneuver, and if we don't see a result, we can move on to some more rarely done maneuvers. or the Dix-Hallpike works and we see a response, and then we can smoothly transition from there into the maneuver that will treat posterior canal BPPV, which is called the Epley maneuver. But the point is, so due to the geometry of the semicircular canals, successful treatment of BPV requires that the involved canal be placed such that the gravity can move the particles through the exit path. And audiologists can complete specific maneuvers. The type of maneuver depends on the type of BPPV, which is determined by which canal is affected. And patients typically see us about 2 to 3 times for these maneuvers. They usually get better, but if they don't, we refer them for further treatment, which may include vestibular rehab therapy with physical therapists or occupational therapists. Next, please.
Yeah, so these treatment steps, as she was saying, you have the repositioning procedures, which is the initial therapy. That's kind of what is gold standard for beginning with, also known as canal reposition procedures, because we remember those 3 canals, they all vary on the type of treatment maneuver that we might do. We have vestibular rehabilitation therapy, which is a special form of physical therapy performed by a physical therapist certified in VRT. If an audiologist refers an individual to VRT and it's just regular physical therapy, there are no benefits related to that. There's medications that have been prescribed. They're often prescribed, we see in our field a lot by otolaryngologists, but clinicians should not routinely treat BPV with vestibular suppressants, because all you're doing is like putting a Band-Aid over a huge cut that needs stitches. You're not helping them acclimate to it and actually help cure the BPV. You're just like getting rid of the symptoms that it's causing. So you want to refer to an appropriate professional when warranted, and education regarding recurrence. If you have BPPV, you are extremely likely to get it again, especially if you have like a vitamin D deficiency or issue with calcium or bone issues, because those small crystals are made of bone. And so we've seen that a lot. It's like the new studies are looking at vitamin D and stuff like that.
Okay, so of course, BPPV is not the only thing that causes dizziness. 2 other somewhat common conditions are migraine-associated vertigo and Meniere's disease. So migraine-associated vertigo is also known as vestibular migraines. A migraine is a neurological condition that causes intense, debilitating headaches. Typical migraine symptoms include nausea, vomiting, difficulty speaking and moving, numbness or tingling, and aura, which is sensitivity to light and sound. Someone who suffers from vestibular migraines may experience all of these symptoms and dizziness and possibly tinnitus. So it's characterized by recurrent migraines with vestibular symptoms, and it's important to note that the vertigo that they experience cannot be explained by any central or peripheral pathology that the patient may have. Meniere's disease, or its predecessor, endolymphatic hydrops, is the inability of the inner ear to regulate endolymph. So sometimes it might make too much, sometimes it doesn't make enough. And endolymph is the fluid in the membranous labyrinth of the ear. And that's characterized by fluctuating low frequency hearing loss, roaring low frequency tinnitus, episodic vertigo, and oral fullness or pressure. So appropriate testing is essential for making a differential diagnosis, especially between these 2 conditions because they present similarly. To do this, we need a very thorough case history. And oftentimes we'll go back and ask even more questions when we're done with the testing just to make sure everything makes sense. Audiometric testing to rule out other otologic conditions, a VEMP, which is vestibular evoked myogenic potentials elicited from the sternocleidomastoid muscle, a VNG, which just is another test that more that like tests not the entire vestibular system, but more parts of it. There's not really one test that tests all of the vestibular system. And of course, we need to rule out BPPV. And then on the side, there's just like a whole list of other conditions that could possibly be related to dizziness. Next, please. Okay, one more thing that audiologists do, which is what I'm very interested in, is called intraoperative neuromonitoring. So intraoperative monitoring is electrophysiologic testing done during surgical procedures. It reduces the surgical risk by providing insight into the nervous system so that we can monitor the patient's condition during the procedure. So if any critical changes in the readings occur, we can calmly inform the surgeon of any potential harm, which may decrease the chances of nerve damage. It's used in spine, peripheral nerve, vascular, and brain-related surgeries. One of the most common tests that we run is something called the stimulus-triggered electromyography, which is just a triggered EMG. So the surgeon can use a probe to map out the nerve, and oftentimes it's the facial nerve that we're looking at. And the goals of this specific test are to identify the nerve, localize or map out exactly where it is and its path in relation to to where the surgeon's working, and continuity, which just means is it intact or not, and then viability, which is just does it work the way it should. I think this area of our scope practice is super cool. And yeah, that's it. Or next.
All right, there we go. Sorry. So we do have a virtual tour of our facilities on the 9th floor at the LSU Health Sciences Center. It does include speech pathology as well, but for the most part, you'll be able to see kind of where we do most of our training and where we go to class and stuff like that. So here we go.
Welcome to the LSU Health Sciences Center virtual tour of the Communication Disorders Department in New Orleans, Louisiana. We are located at 1900 Gravier Street in the Allied Health Nursing Building. Our department occupies the entire 9th floor of this building. We will show you some additional space in the Human Development Center located just a block away. You will not only have academic classes on the 9th floor, but our audiology and speech language clinics are also located here. We have several classrooms on this floor, as well as in the Human Development Center. Audiology and SLP graduate students take 2 courses together in this program: Anatomy and Physiology of the Speech and Hearing Mechanism and Neuroscience. Students also participate in interprofessional courses and have opportunities to work together with other students in many different programs such as occupational therapy, physical therapy, PA, nursing, dental, and medical schools. Let's take a few minutes to visit our on-site speech and hearing clinic. Patients check in and complete paperwork before their appointments. In the audiology clinic, we have several audiology suites with state-of-the-art equipment. Each suite has audiometers and middle ear analyzers. We have equipment for distortion product emissions and transient evoked otoacoustic emissions. We also have several hearing aid fitting and modification rooms to service the needs of our hearing aid patients. This is one of 2 electrophysiology labs. Here we record the brain's response and the brain's time to sound. Audiologists play an important role in the diagnosis and management of patients who have vestibular issues. Let's continue to the SLP clinic and observation rooms. The speech-language pathology clinic has a dual purpose. It is used for clinical teaching as well as providing services to individuals with speech and language disorders. It includes many clinic rooms where speech-language intervention is provided to both adults and children. Examples of services include children with articulation, language, literacy, and fluency disorders, as well as adults with aphasia, dementia, and traumatic brain injury. Our clinic is also involved with voice and message banking for patients with degenerative disorders such as ALS. The computerized speech lab is used for assessment of and intervention for clients with voice disorders and feminization voice therapy for transgender individuals. The nasometer is used for assessment and intervention for individuals with craniofacial anomalies, including cleft lip and cleft palate. State-of-the-art AAC devices are housed in the Assistive Technology Lab located in the Human Development Center building. Both low and high-tech devices and a variety of switches and access methods, including eye control and head pointing, are used during assessment and intervention. We hope you enjoyed this virtual tour of the program. We have many other points of interest that you might use while attending school at LSU Health Science Center, such as the full-service cafeteria.
All right, I'm sure y'all don't need to see our cafeteria, but we also have libraries. Let's see here. No. Okay, there we go. So just, I know that was a lot of information thrown at you. I do want to stress that a lot of older people are having problems with dementia. And I do want to mention, because this just recently came out, that dementia and untreated hearing loss are correlated very strongly. So just be aware that if your patients are struggling with hearing loss, the best course of action for them is to, if you know they have hearing loss, go ahead and try and get them into some hearing aids, because studies have shown that those who are amplified and who keep their brain strong through hearing are less likely to develop dementia. Like I said, I know that was a lot of information thrown at y'all. If y'all have any questions, now would be the time to ask if we need to clarify anything.
Thank you guys so much for presenting. I personally don't know a lot about hearing loss, and I feel like I'm not alone in that. I'm a public health professional and I think of myself as a generalist, but that was, yeah, I mean, you're getting a lot of good feedback in the comments. And so I hope you feel good about what you just presented. So that's my first thing. I guess I'm curious about what it means to get maneuvered.
Yeah, so maneuvering is lots of different positions. So you have to the vestibular system is a whole monster in and of itself. And to be positioned and maneuvered, you'll be in supine position, and then what we do is we take you and we have you come back and we watch your eye movements, because your eyes and your ears are connected. So depending on the way that they move will kind of tell us which other way that we need to turn you. There are things such as like an Epley or anything like that. Any of my classmates, feel free if you want to elaborate on it.
Yeah, I mean, so the maneuvers really just depend on what kind of BPPV you have. The one that she was talking about just now, that's the Dix halt pike, and we lay you back, we kind of make you look like this, up and to the side, and we look at your eyes, and then that goes into this. It's just the Epley mover, and we can kind of turn your head and flip you around in certain ways. There's different ones where we have you like sit up straight and like going from side to side and use your momentum. We have ones where we're just moving your head back and forth and you don't have to do anything. We have ones where we're turning you over, or there's even one where you're almost doing a somersault. So it really just depends on what you need.
There's
Yeah,
a lot there's like a lot of stuff you have to look out for, like cervical issues and things like that may not allow you to do them as well.
I did have one question. I thought it was so cool. It was the monitoring like you could do during like spinal surgery. Was that correct?
Yeah.
Could you remind me, was it like you're tracking, was it the facial nerve or what nerve was it? Like,
So the facial nerve is just what I did a rotation in that area, and that's just what I saw the most often. But it really depends on what the surgeon needs and what the surgery calls for. That triggered response helps the surgeon find a specific nerve. So basically, he knows like, okay, don't cut this. But there's other tests too that can let us know about anesthesia, like how light the patient is or what the patient needs. There's other tests we're just monitoring in general. We want to know that, your toes are still going to work at the end of this, even though we're working on your neck. So that too, it just depends on what's needed.
Yeah, it is.
Yeah, really fascinating.
It is really important that pretty much all of your nerves come out right underneath, like right in the back of your head. So a lot of nerves come out. There's like 5 major cranial nerves. So like Val said, intraoperative monitoring is really important for those. So they have to be very, very careful. And that's really the role of the monitor, is so that you don't cut something and end up paralyzing some part of the body for the patient.
I do want to add too that like that area is not just for audiologists. So there's layers to it, because we already do electrophys testing and we have our doctorate. We can supervise other people to do it too, and we kind of have a really good understanding of the nervous system and everything that goes with that. But there are people who are just essentially technicians. They can do that too, and they're supervised by someone else who has the doctorate. It could be another ENT, it could be an audiologist. And typically those are the people who do the monitoring. But anyone with a bachelor's, and like you'll go into like extensive training. It's not like anyone off the street, but it's open to more people than just audiology.
Thank you. I have a question about, so we had talked about when we learned about the dental school last year, a little bit about the hoax that is dental insurance. And I was just realizing that like audiology is covered under medical insurance, whereas like vision and dental are kind of different. Do you have any understanding of the history of how it's paid for and how it's included?
So I'll mention this. A lot of insurance companies have been going through what we call third parties, and those third parties are very complicated in like what they allow to be paid for per ear. But a lot of companies don't take that insurance. I know right now that's a big deal is with Ochsner. Ochsner is like providing hearing aid insurance, like with however much off of what they cost, but then no Ochsner provider in the state does hearing aids or accepts insurance for hearing aids. So you have to pay the full price, even though you've already paid for that insurance. And then they're coming to like my private practice clinical location, and they're upset because their insurance isn't qualified anywhere because even the place that they bought it through isn't taking it. So insurance is a big issue right now, and I'm hoping in the next couple of years it'll get figured out. But currently, a lot of people are having to pay out of pocket for hearing aids, but there are very good programs, especially there's one here in New Orleans that aids in providing the money for hearing aids to those who may not be able to afford them. If anyone else wants to add to that.
I think the coverage that you're also speaking about, Nora, for the most part is diagnostic testing. Like Lane said, most insurance companies do not offer anything for hearing devices, and if they do, it's very minimal. But diagnostic testing, for the most part, is covered. There's still some tricky things around that too. As far as the history of why that, I'm not sure. That's a really good question. I know that audiology in general was started as a result of World War, is either one or two? Two? Okay, thank you. Because soldiers were coming back and they were having hearing problems and we needed someone to address that. But as far as why insurance covers it more than vision, I don't know.
It's something you have to really look into whenever you're purchasing it. I know some companies will tell you have that coverage, but only if you're under 21. Like there's very big pitfalls. You have to which it affects those people who aren't educated about insurance. Like I don't know everything about insurance, and so when you're purchasing that, you kind of are trusting the people selling to you, and that's some of the issues too.
So, like I said, I'm in my residency. I'm in my 4th year. I'm in a private practice, and guess what we do? We do hearing aids, and it changes often, very often, even sometimes month to month. But like they said, there are third parties that can help. Right now, um, technically there is no insurance cover. No insurance covers hearing aids fully, period, point blank. Some insurances may have a benefit. Patients need to call and see if that's covered. Humana and People's Health have really good benefits through a third party managed care plan called True Hearing. The only thing that happens with that is the reimbursement for audiologists is not great. So we, as a profession, we cannot survive just strictly on third party. However, I have seen people come through who, they can only get the bare minimum, and you know what? That helps them out, and that's great, and that's what we want. So a lot of audiologists are a mix between third party and private pay patients. Uh, Hearing aids for 21 and under usually I want to say are covered, but again, that's not my area. I'm dealing with mostly geriatric patients right now. Medicare does not cover hearing aids. However, there is plan in Congress, there's legislation in Congress, COVID put a hold to it, that insurance will start covering some sort of hearing aid thing, like some sort of hearing aid, putting some sort of benefits towards hearing aids. May not be much, but it can make a difference. Insurances usually do cover the cost of a routine hearing exam, which we recommend every year. I think it's at like after age 45 or 50, you should start getting a routine audiogram every year, just to make sure that nothing changes. But also, if you feel like you're having hearing problems, by all means, come in and get a hearing test. It's always good to have a baseline in case something does happen. COVID has been shown to have some hearing loss symptoms. Some people have come into the clinic and they have lost their hearing and they're not sure if it's come back. Some people have had meningitis and they have completely lost their hearing in 1 year. Some people bounce back, some people don't. But insurance wise, that is a monster in and of itself. For the most part, no, they do not cover hearing aids. If you have People's Health or Humana, those plans right now, those are pretty good. But as far as other insurances, if you or somebody you know needs hearing aids, I would call your insurance company to see who takes, if and who has a benefit, because it's always beneficial for that.
As we said, for children, I'm seeing children in clinic right now, and I know that some insurances pay for hearing aids every 3 years. So even if the hearing aid is still working, they can get a new one through the insurance.
And that's important for kids because they're very hard on hearing aids and they like to lose them. And, technology changes a lot over time. It's rapidly changed in the last 10 years, as Lane had mentioned. It's rapidly changing. It's constantly changing. There are new things out every 2 years or so, year and a half, 2 years. So anything else? Anyone else have any questions?
I had a quick question. So you guys said you work really closely in hand with ENTs, which makes a lot of sense to me. But do you guys work a lot with like generalists, general physicians, or like general practice, or would it be more like a generalist is going to refer them to a specialist who's then going to refer them to you guys?
Sometimes we are the specialists that they refer us to. I haven't seen where we work with a lot of general physicians, but I think that's just as important for referrals and important to have those relationships.
I think I think it's again one of those interprofessional and like community type things. A lot of the audiologists will reach out to general physicians or ENTs, and even ENTs will sometimes reach out to other regular people or general medicine, and make those connections. But when it comes to they'll probably general practitioners will probably refer to an ENT, and usually ENTs have an audiologist on site, and if not, then that ENT usually probably knows an audiologist that they can refer to. Trying to think. Oh, also, by the way, ear candling, no.
So on that topic, what is the best way to clean your ears?
Best way to clean your ears. So like Lynn said, especially for earwax, there are over-the-counter products where you basically put some drops in your ears, let it soften up the wax. You can then rinse out your ears that way. If you know that you produce a lot of wax, I would say go to an ENT and have it cleaned out periodically, because it is your body's natural mechanism of getting it out, of getting things and debris out of your ears. But sometimes, some people's ear canals are very, very curvy, and earwax just doesn't want to come out. So then you kind of have to dig it out. ENTs kind of have better equipment than just regular private practice audiologists do. A lot of times in my clinic, if the earwax is like, right there, not too far, we'll grab it and clear it for testing. If it's too far back and too hard, we will refer out to an ENT because they have better equipment, a little bit better training for that. But just as routine maintenance, do not use Q-tips. Do not use them. All they do, especially if you have small and curvy canals, that'll just push it back, and then it'll get right up on your eardrum. Then your eardrum cannot move. And I saw someone say you love Q-tips, and you want to know why? Because there is a nerve in there that you hit whenever you do it, and it feels really, really good. But I would say if you are going to use Q-tips, do not, use it for the outside, use it for the pinna, for cleaning the pinna, and like just right there at the beginning of the canal. Don't stick it too far in, because too many accidents have happened where people, like, all of us, like, they're cleaning their ear and someone comes and like shoves their arm because they don't know they're in the bathroom, and it goes straight through your eardrum. And that's painful in and of itself.
She's speaking directly to you guys who are in the chat, like, I'm not giving up my Q-tips.
Saying you have to give them up, but I'm saying if you are gonna do it, please be very, very, very careful.
Also make your ears itchy. I don't know if anyone, I use Q-tips. I know I should admit that, but I do. I love them. But like I'll put like baby oil on my Q-tips and only use it on the edge, like she said, because just the nature of like the material, it dries out your ear canals. And I'm always like, oh my God, why are my ears so itchy? And it's because I use Q-tips.
Yeah. And that I've seen that a lot. A lot of people are like coming to the clinic like, my ears itch, so I use a Q-tip to get it. And then I look in their ears and it's dry, it's red, it's flaky, it doesn't look very happy. And it's just because it's very cyclitic, it itches. So I put something that's gonna dry it out and make it itch more into my ear, and you just keep doing it. And it's really just not that great. Yeah. Also, if you stick the Q-tip too far down in there, you'll cough. Or if anyone messes with you, there's a cough reflex. What is that? Your vagus nerve, cranial nerve 10. Am I correct on that one?
There's like 4 nerves that innervate your ear, different parts.
Yeah. There's a lot, very big nerves. And number 10 is the one that's making you cough. And like when you get dental impressions, I believe it's the one that makes you gag too.
Cool.
So lots of nerves, lots of things. Hearing organ and balance organs are right next to each other too. I wasn't sure if that was very clear in the presentation, but the little snail, that's your hearing organ, and the little loops, that's your balance organ. That's part of your balance system. And I think that's everything that I can think of that I wanted to mention. Anything else from you guys?
Like I said, these are always crowd favorite presentations. And so I'm really, really happy that you guys pulled together and decided to do this one. So thank you so much. Don't forget to log all of your time spent on preparing at a service. That's another thing, you guys, if you volunteer, even better, but I might come knocking on your door, and you get service hours for whatever time you spent preparing. So really quick few reminders before you go. Don't forget to sign up for free admission to the AHEC conference. It's a really good opportunity to network with other scholars. You are part of a national program and learn a bunch of stuff. And it's free, so why not? And you can get tons, there's even experiential stuff woven into it. So if you need hours, this is a really good opportunity. Secondly, don't forget to sign up for the pharmacist if you want to participate in that. And finally, let's all raise our hands up and do a big wave for a clap for the folks for joining us today and presenting. Thank you guys so much. This is awesome. I'll be sending out the evaluation soon. Thanks, everybody.
Thanks. Bye.